provide a very quick round of introduction. So Karkinos is a young startup. It's close to about 4 years now that we've been part of the journey. And primarily the major role that I have been part of here in this organization is necessarily strengthening the entire early detection and prevention roadmap for the country in India. And primarily, we have essentially seen that, I'll just set up India's cancer as a context. We've obviously seen the number of cases are on the rise. When we talk about it in the context of the overall country, we believe that oncology or cancer in particular will be the next cardiology for India, which is that many cases on the rise. And particularly from a context of screening, we've essentially seen less than 2% screening in the space of cancer, oral, breast, cervical, and any other types as part of the overall NCD program. Also, while obviously there are a good number of facilities in the major cities of the country in terms of being able to treat for cancer, we still have a major roadblock in terms of providing for affordable and accessible care closer home. So by the time the patient or the citizen who's identified of cancer reaches a cancer hospital, primarily in the country, we say they're already in a stage 3, stage 4. So our ability to, in fact, save lives as well as being able to provide for a quality of life that is reasonable becomes extremely difficult when it comes to a situation like this, which I think broadly is the case largely across the world. But in India in specific, with so many different states and population levels, and with the sort of urban-rural divide that we have, you will see many different examples that I'll be able to highlight. We potentially see there is a great degree of access challenges when it comes to complete oncology care. Some of them only providing a chemotherapy, but a radiation facility may not be available in many different places, or vice versa. There are many, many different challenges that we foresee, and with many developed economies already adding so many linear accelerators, in India the burden is still very high, and the shortage of supply both in terms of manpower, equipment, as well as our ability to treat for population closer home remains absolutely the key to, in fact, providing a solution to this problem. So with that as context is where Karkinos was envisioned as a oncology platform. This is more a technology perspective to be able to provide a way forward for us to discover new solutions for India, with providing for delivery for care, which is closer home. So I'll give a brief in terms of what we want to cover in the next 30 minutes, and we look forward to questions, comments, and learning from each one of your experiences as we go ahead in this journey. On the overview of Karkinos, so with that as context with respect to India, I'll just quickly talk about what is the overall vision mission that we have. In the country, we've essentially had a lot of cancer centers, obviously focusing also on being able to provide for screening services and prevention related aspects. But healthcare is quite fragmented, and that's probably true across the world as well. But more so here, we see that there are organizations obviously doing a lot of work in the space of providing for awareness, as well as ensuring that more and more people become aware of the importance of early detection and screening. But to be able to afford and be able to also get access to the reasonable right diagnostics, and then to follow through if somebody was actually suspected of a cancer, get a delivery of care closer home is missing. So healthcare from a Karkinos oncology perspective, our entire roadmap is to improve this entire accessible care and affordable care. But to doing this in the model where we discover for India based on what we can do, closer home delivery for rural as well as semi-rural urban population. Start with the detection, and if somebody were indeed detected with cancer, then democratize essentially the diagnostics for the same, and provide for a model where you can have a precision oncology in place. In India, it is extremely difficult that only the rich are able to afford for precision based molecular technologies. But how do we really move from just a morphology based decision making to a molecular based testing and provide that as care for everyone across the country, whoever requires that? Is the model that we are looking at. So 4Ds is really our principle that we essentially look at. And from the overall perspective of being able to bridge this demand supply, we focus on wellness in terms of early detection. And when it comes to providing delivery of care, I'll talk a little bit about how we look at a hub spoke and further spoke model to be able to create care delivery, and also our entire patient navigation platform in the form of a command center handholding patients throughout this journey, so that there is an absolute methodology to this entire roadmap, that patients don't get lost to the entire process, and we empathize with them as part of this journey, and all doing so with obviously the best of multidisciplinary care team in terms of clinicians who can be guiding us throughout this entire journey using a clinical decision support system as a platform. Next slide, Lakshmi. So, what you see on the left hand side, that's more in terms of how we operate with respect to delivery of care. Um, in the most rural of settings, you might call it a primary healthcare center. We would and have collaborated with multi specialties, PHCs, primary healthcare centers, community centers to provide for screening programs in terms of building a network where the entire screening for oral, breast, cervical cancers, even colorectal cancers can happen. And to a certain extent, if possible, even a certain base minimum delivery of care can also be set up at the grassroots level. And the L3 level models are where we are working with centers who have a multi-specialty, where we can essentially develop some local diagnostic facilities with respect to imaging, radiotherapy, as well as can provide for bare minimum basic surgeries that can be operated at those centers, and also can provide for daycare chemotherapies. Medical colleges and tertiary setups are those L2 centers where we collaborate and work to create an oncology unit. If today it may be missing, for us to be able to make it a comprehensive center. And L1s are, of course, center for complex cancers, epic centers where we can provide high-end oncology. This model essentially helps. So for those of you who know India, why should anyone have to come to a Mumbai, Delhi, or similar such metro cities? But why can they not sort of avail for care if it is in a district where they live, even though they may not have a complete comprehensive center? If they indeed needed just an ability to go ahead and perform a surgery or a chemotherapy. But yet, of course, with an absolute comprehensive clinical decision support system guided by the right methodology is really the model. So we've built a network of these centers, and they are all tied together on a digital platform, which we call as an L5 layer. So that's the oncology network platform, and which obviously is guided based on clinical decision support systems, where we have developed clinical pathways, which are essentially based on the NCCN NICE guidelines as well as the physician data queries and India's very own National Cancer Grid sort of registries in terms of pathways. And all of this is being sort of internally modeled around the knowledge repository of Karkinos, where there are board of clinician experts who form the virtual tumor board, guide the entire roadmap, and the command center to help with the patient navigation. And the entire laboratory related to the diagnostics is modeled around our own CAP accredited labs, where we have starting from molecular, testing from histopathology to genomics, really modeled for the country in a democratized fashion. Next slide. Here's a basic with respect to the command center operations. One of the major roadblocks that we've seen is today the citizen who's suspected of cancer or is confirmed of cancer essentially doesn't know what to do next. Our ability to guide them, navigate them help them throughout the process seamlessly as part of the care pathway, counsel them. A lot of people sort of leave the cancer care midway, try and help them throughout that journey so that they don't leave the treatment behind halfway through, and also ensure that they have the right guidance and information across the board. So we have a coverage across multiple languages in India to be able to guide the patient through this network. And here's just a glimpse of our, facility with respect to the laboratories. We have two CAP accredited labs, one in Mumbai as well as in Kochi. Also with a very good academic rigor that we work to be able to model the next generation work and ensure that we do research for India to be able to see how we can bring the right models of delivery solutions, and anything else in terms of what we can discover for the country is what we are essentially doing within our labs. And it obviously covers for all models of oncology, diagnostics. And coming to the major area of our focus, our major area of focus is on the early detection and prevention space. We look at common forms of cancers that can be preventable, which includes oral, breast, cervical, as well as colorectal cancer. And largely goes with the health risk assessment. And for those with elevated risks, and with signs or symptoms in terms of suspicion, we take them through the screening program in community setups as well as the vaccination roadmap. And for those who are indeed suspicious of screening, consultation or teleconsultation, and then take them through the next level of diagnostics, and the entire journey sort of continues if they were to confirm cancer. Help them throughout the journey with respect to treatment as well. Now, I'll quickly go over some of the major areas of work that we've done. We've risk assessed more than 2 million population. And so far, given cervical cancer elimination has been a very important area within the last 2 years of work, we've done about 50,000 cervical cancer screenings using HPV DNA test, which is WHO recommended. And also have recently started close to about 11 months or so now in the vaccination journey. Have done about 8,500 vaccines administered, and we've treated over more than 50% of those who are tested positive for HPV DNA testing, and about you know 1.5K cases that have gone through the virtual tumor boards. And our command center supports more than 20 plus languages, and more than 50K patients have been navigated through the centers. So the network that I talked about, L4 to L1, we have about more than 65 plus partners as part of that network to be able to provide for care locally. A quick glimpse in terms of our clinical team. Dr. Moni Abraham Kuriakos is our overall medical director, who's also global chair of head and neck cancer. And he's also had a very important role in setting up some major oncology setups in the country, and is very passionate about driving community as a cancer center as a concept. Dr. R. Shankar Narayan, most of you would obviously know Dr. Shankar, who was the former director of prevention at WHO at IARC for many years. Post his retirement, is guiding us full time as our director of preventive oncology, and majority of our cervical cancer elimination programs as well as many other early detection programs are guided under Dr. Shankar's directions. And Dr. G.K. Rath sir, who's also a former head of NCI in India, and several others who have been part of our journey, passionate about being able to drive this care. Also, we have a scientific advisory board, which is a combination of national and international experts from Harvard Mass General as well as from the Mayo Clinic, and leaders who have been former CEOs of American Cancer Society, heads of pathology, and others who have been part of our journey, guiding us throughout this entire roadmap. It's indeed a great privilege for us to have all these clinicians and scientific advisory team. For us as a startup, means a lot in the journey. I'll just take 15 minutes to talk more about our specific area of work in the cervical cancer elimination work that I lead. We are thoroughly focused on all the three pillars of the strategy with respect to what WHO has guided under the SDGs 2030 goal of 90, 70, 90. So quickly take through what we started out first, which was the journey of screening, and then move towards vaccination. So we've educated over 100,000 families in the entire journey to be able to guide them on the importance of early detection and prevention. And this has been done largely around the clusters that we operate, but also quite a lot in Pan India as well. And post these early detection screening education programs, we move forward with the screening exercise. So far, we've done about 52,000 HPV DNA tests across 21 states in India. India is obviously quite diverse and quite a lot of population to touch. So 50,000 may not seemingly look large, but it is indeed a very important number for us as a country, because HPV DNA test, contextually for most of you to understand, still not part of our national guideline for the country, still under the umbrella of visual inspection with acetic acid. So we're not in the journey of HPV DNA test as part of the formal guidelines as a country, and hence this number of 50,000 HPV DNA tests across 21 states is a significant number for us within the 2 years journey that we have started out. Our first year was indeed a struggle, because that was the year where we had to first talk about HPV DNA test. Why is this important? How this is WHO recommended? Why this is a more sensitive, specific test, better than the models that we are already adopting? How this can be largely also implemented in the country much faster, given the self-sample collection and other methods exist. And so it took about 9 to 12 months to even begin the entire course. And then largely the numbers that we see have been done in the second or the year and a half post that. We work closely with majority of the community partners, self-help groups. In India, we have the ASHA workers who work closely with all the rural households, who go door to door to be able to guide them in the aspects related to health. We work with government factories, tea plantation networks. We've adopted multiple strategies with respect to screen and treat. So we screen, of course, with the HPV DNA test, and for those who are screen positive, we also bring them back for a see and treat model with colposcope, thermal ablation, and leaf. So we'll talk a little bit about it. We've also done a good degree of work for PLHIV, vulnerable population set, and also have collaborated in this space, particularly for PLHIV, with uh, state AIDS control society, with trying to implement this across some of the ERT centers in a few states, and with other community outreach programs where community pharmacy clinics can also be a model that we can adopt. So that's the large window of the total population that we have touched. You will see that almost 70% were in the age category of 30 to 50, and that's the number who have largely participated in this journey. If we go next, Lakshmi, we have seen a positive rate of approximately 10%, and a breakdown in terms of the HPV genotypes that you can see between, of course, in India, 16, 18 being the large population set, but the rest of the HPV others is also what you see as outlined. Of course, positivity rate has been much higher when it came to PLHIV, which is um, quite normal. We would have anticipated that. It has been around 27% that we have seen. Next slide. The way we've modeled these screening programs, and the execution is obviously the key. So we begin with the self-help group community awareness programs, giving them awareness booklets in local languages and so on. And Then we go ahead with the roadmap with respect to registration and counseling them in terms of importance of prevention, early detection. Talk to them about how a particular screening program will be conducted, because a lot are apprehensive in terms of cervical cancer screening in the country, so they don't usually understand the importance of it, nor are they appreciative of the process that they have to go through. And so it's important to counsel them in terms of the journey and what it takes to be able to screen. And then post the consent, we go ahead with creating a registration number. In India, we have an Ayushman Bharat digital mission. So our ABBA ID is created. Our platform is guided and well connected with the, country's ABDM methodology, and we are already mission compliant. And post which we look at the vitals and we screen not just for HPV, but we also do oral visual examination, clinical breast examination, and we have in several cases where possible, we also do a fit kit for colorectal screening as well. And post this, for those who are suspected positive, there is a post report counseling. And for those who are tested positive, we also take them through the entire treatment of pre-cancer lesions for HPV. And where necessary, we do the same for next level of diagnostics for breast and oral. Which includes maybe mammography, ultrasonography, biopsies, and the next sets. In colorectal, we look at colonoscopy. Next slide, Lakshmi. We offer, of course, I mean, there is a perception of price in terms of HPV, and that's really one of the major challenges and the barriers for adoption in the country. But of course, we try and educate people the aspect that this is not a yearly exercise based on the WHO recommendations once in 5 or 10 years, that women can in fact go through this exercise. So a cumulative effect of actually taking a test every year versus doing this once in 5 or 10 years, the price aspect obviously becomes lower if you were to take HPV. And this is the highly sensitive specific test. So we give them all the benefits in terms of what this means to them. And we've also priced it in an affordable category, primarily because we want more and more adoption towards it. And we use the Cobas platform, which is an FDA approved as well as WHO pre-qualified platform, Cobas 6800, to be able to test for HPV DNA. And we are able to provide the results, of course, keeping the logistics with respect to getting the samples to the lab. We are able to give them a report in the immediate next day or maximum 2 days. Next slide. There are various models in terms of financing that we have seen. We've essentially seen people going for self-financing, which is quite uh, not the case in rural areas, but I have an interesting case study to show in this particular space. We've also had community programs where microfinances have covered this for their self-help groups, corporate employers having plans to be able to cover HPV, or CSR fundings for us to be able to do this for underserved. But large challenge still remains that for India, HPV DNA test is still not part of Ayushman Bharat's national coverage, nor is it yet there as covered under even the private insurance scheme. So this continues to be a challenge for us in the country and an issue for advocacy. Um, we have done about 500 plus self sample collections, and this method has also had its way forward. There are where people ask for self sample collection, we go ahead and use this technique. We have self sample methods either with Copan, or in India we have a survey check, and we have different ways of being able to get this done as well. I'll just show a few case studies for us to be able to demonstrate how we've done this exercise, and would love to learn about your experiences and any challenges or relatable stories that you may have, and any lessons learned that we can take. So one of the major important criteria for us is to be able to look at us as a way to not have any women for loss to follow up, and ensure that the entire longitudinal mechanism of being able to guide them through the journey happens. So here's a very interesting program. Pallivasal is one of those tea plantation locations, which is in the district of Idukki in Kerala, which is the southernmost part of India. And this district has absolutely zero cancer centers as of today. And what we did was for the entire panchayat, we screened all the family members. Uh, it's a small panchayat, and we literally went door to door with the group of people who were trained to in fact do health risk assessment on our platform, which is on an app where they have a certain set of 50 to 60 questions which can help, which is also in local language, which helps us understand clinical history, family history, signs and symptoms, and aspects and behaviors which could possibly lead to elevated risk with respect to health. And based on those who were at elevated risk for oral, breast, cervical, or colorectal cancer, or even lung, we bring them to a screening program which was done over a period of time. Oral breast cervical. Here's a lady, who's 54 years old, who was tested for HPV positive in our screening location, which you see here is the green location here in the map. And then what we did was we counseled and got this individual uh, to the nearest center where the colposcopy examination was performed. And we take a see and treat approach. But given that our colposcopy had suspicious results, the biopsy was taken and it was sent to our Advanced Center for Cancer Research Lab, which is in Kochi, which is an adjacent district that you see. And then, based on the biopsy results, a virtual tumor board was conducted, which is obviously largely online. And based on the results, the surgery was recommended, which was planned in the partner hospital of Karkinos, which is what you see here on the screen, which is in maroon. And post the hysterectomy, of course, we guided them through the entire journey of ensuring that the quality of life and the next steps are maintained. So it's a very interesting storyboard in terms of, not always everything needs to happen at a cancer center, and yet we are able to detect a case early and prevent them from, in fact, becoming a very high risk cancer, and are able to do this in a community as a cancer center model with technology backbone as well as patient navigation concepts. We use colposcope and thermal ablation leap and those kind of technologies which we carry with us. The next interesting case story is that of a model of self-financing, where we've seen a very interesting case story where in a particular district the self-help group, who is led by, of course, a leader of their particular organizations, very well respected, who was very keen for their women's health and introduced the cancer screening program for the self-help group. The women themselves post the awareness programs and the guided counseling that happened have come forward to be able to screen themselves, paid for the screening program themselves for individual screenings, and about 10,000 of them have been screened in a matter of year. This program continues with some other partners, and oral breast cervical screening done with HPV DNA test for cervical, and we've seen a positive rate of 10%. For those who were tested positive, they have also been treated in a nearby hospital for pre-cancer treatments using the mobile ODT techniques or thermal ablation and LEAP. Next case study. We also have our mobile medical unit using our foundation, which is also going to places where it is hard to reach population and bring them cancer care closer home, and where we've screened more than 1,500 plus audience. And this has only been, work ongoing initiative for the last few months. And we've done overall screenings, which also includes the mammography within the mobile medical unit, and a colposcopy is also in there with the thermal ablation and LEAP for us to be able to perform pre-cancer treatments also in a community setting. Next slide. The next one being a program which is quite interesting, because I think one of the major initiatives is of us being able to do this for high risk population, and this is also a population who needs HPV DNA testing or cervical screening most. In a very interesting public private philanthropy partnership model, we have been able to demonstrate that in a collaboration with the Madhya Pradesh State AIDS Society and a CSR funding coming from few of the local within the state institutions, and us as a execution partner, we've been able to screen women within the ERT centers where they come for already treatments and medication for HIV treatment. And in there we treat them for oral breast cervical cancer, and then particularly HPV positivity rate was seen as 27%. Very interesting to note that Madhya Pradesh very well equipped already based on some of the past work done by some of the other partners in the region, where district hospitals are equipped with all the devices of colposcope, thermal ablation, and others, that the women are able to go to these district hospitals and for free of cost are able to avail the services for further investigation and pre-cancer treatment. So a very interesting storyboard which can actually be implemented as a policy across the country with very minimal funding expenses to the government. I will go to the entire. We've been able to across the board for those who have been positive. 50% of those we've been able to navigate them through the journey. The remaining 50%, there are many gynecologists individually who take HPV DNA tests, and we have information that the women who are tested positive there are also treated, but they've not gone through our platform. So the 50% who have gone through our platform is what we've noted here in terms of colposcope biopsy and the rest of the treatment. Move ahead. On HPV vaccination, we've so far since November of last year done about 8,500 doses. Our model is a very integrated health model of us being able to look at many different methods of application. Whether it's test the mother, vaccinate the daughter program, or take this particular health initiative together with education, that we do this across the schools program and initiatives, or do this for people who are children of vulnerable population. Like if you are a vulnerable, we have another program where we are doing screening for HIV positive. So the children of the HIV positive women, or even the child itself, if they are vulnerable, being able to integrate these vaccine programs across multidisciplinary health initiatives that we have, and make the education awareness happen, and obviously ensure that the delivery of vaccines happen in a more quality assured manner, is how we've in fact approached this. We offer both Gardasil as well as India's Servovac to the beneficiaries based on the beneficiaries selection of vaccine, while we counsel them of course on the benefits of one versus another, one dose selections versus others, and so on, based on what the guidelines say. And we bring them awareness, consult them. We even provide individual consultations and as needed home vaccinations as well, or we provide and conduct vaccine camps, and as much as possible also promote a one dose regimen. Dr. Shankar and his team with Dr. Partha Basu and others, we have 9 sites, study on HPV vaccine, which has been ongoing, of which 2 of the sites are part of Karkinos' network. And the most recent publication on one dose vaccine regimen has been from some of these studies that have happened, and very happy to in fact see some of those publications. And we promote one dose if somebody were challenged to be able to take the dose as per full guidelines. And of course, we promote it across our network. The adverse events that we have seen as part of the vaccines have been quite limited. Majority of these have, we've maybe had maximum 1 or 2 cases out of the thousands of cases that we vaccinated, but none of them adverse, and some of them we don't believe are related. Cases with respect to what we have seen in terms of event that was noted. So not going into more details. The last, coming to the major challenges of being able to look at prevention largely from a cervical cancer perspective, I think there is still a lot of stigma in the country with respect to adoption to both vaccine as well as test. This stigma not just in the community, but it's also largely in the network of our own clinicians also, to a great degree, because we don't see a lot of adoption in even writing HPV DNA tests by even the gynecologists today. But of course, there is more acceptance amongst the clinicians to provide for vaccine, which is at least a good sign. Um, where possible, of course, while people do want to adopt it largely, there are, of course, some challenges with respect to being able to look at the cold chain as well as have all those right drug licenses to be able to store large amounts of vaccines. Uh, and being able to have a compliance with respect to next doses, or even for those who are HPV positive, unless we have a patient navigation and a command center like approach. We've seen the loss to follow up for all those people who are HPV positive. So a lot of times also misguided. We've seen incidences where even before our counseling happens, people seen, and gone to some local facilities and have gotten a hysterectomy done. We have challenges which we have to work and counter and continuously work through. We are working across more than 20 plus languages, but in a country like India, language is indeed a major area of scope of improvement, where we have to counsel and do everything within the realm of local language. And of course, we need to be able to ensure that within a limited time of providing awareness, immediate actions towards screening or even vaccination should be taken. And largely, perception of cost always prevails, and that's something I think all of us are working to be able to counter. But with all the collaborations of Gavi and several other things that country is doing, I think there is a major roadmap ahead that we will have to work through. I'll pause here. I appreciate the time that is given to us. I know it has been a long presentation, but we thought it's pertinent for us to share our experiences and also hear from each one of you in terms of any lessons learned or any comments based on what you have heard from us for us here. Thank you very much, Marisa, and to everyone who has been listening in patiently. Look forward to your comments.